Thank you so much, everyone, for being here. I am Shruthi, and I am currently a sophomore at the Davidson Academy in Reno. My mentor is Dr. Ravi Charla, and she is an anesthesiology resident at Westchester, New York. As a quick overview of my presentation, I'm going to go over the objectives of the meta-analysis, background information, the study itself, potential limitations, and finally, results and conclusions. Our objective was to assess whether patients were diagnosed with myocardial infarctions had an increased mortality due to concurrent COVID-19 infection. Here is some general information. So we looked into this because cardiovascular disease mortality, specifically from myocardial infarctions, has been the leading cause of death across the globe and in the US over the last several decades. And the pandemic years of 2019 to 2021 had the largest increase in cardiovascular mortality in any year since 2003. All patients who were included in this study had myocardial infarctions and were split into two cohorts, those who had COVID-19 at the time of their MI and those who didn't. And finally, this study is a meta-analysis with 87,534 patients and 3 studies. So why is it important to study this? As we can see in the table, the annual cardiovascular disease mortality increased by 2 million during the peak of the pandemic. And this was the largest increase in cardiovascular mortality since 2003. I'm going to briefly introduce topics that are covered in the study, which is myocardial infarction and the potential correlation between MIs and COVID-19. But first, here are some quick abbreviations. COVID-19 is the strain of coronavirus that led to the recent pandemic. And MI is a myocardial infarction, but more commonly known as a heart attack. CAD is coronary artery disease. Interleukins are a type of cytokine that are involved in immune cell functioning. The CDC and WHO are health organizations. The CDC focuses on the US, while the WHO is global. A PCI is a percutaneous coronary intervention, which is an invasive treatment for myocardial infarctions with either a stent placement or a balloon angioplasty. And in this case, med.tx will be used to refer to non-invasive medical treatments for a heart attack. So what are some causes and major risk factors for heart attacks? Here are some of the main ones: CAD or coronary artery disease, hypertension, high blood pressure, hyperlipidemia, high cholesterol, diabetes, and obesity. As we can see in this diagram, this is a normal artery with unobstructed blood flow. And as we move to the middle one, atherosclerotic plaque consisting of lipids, calcium, and other cellular debris starts to build up within the arterial wall. This atherosclerotic plaque is highly thrombogenic, which means it's likely to form a clot when it comes into contact with the bloodstream. And in this bottom diagram, we can see that the plaque and the blood clot have completely blocked off this artery. And moving over to this diagram on the right, this section of a major coronary artery has been completely blocked off, which means that the apex of the heart is not receiving blood flow. This damages the tissue and leads to an infarct. But how is this potentially correlated to COVID-19? There are 3 main potential points. The first is cytokines, which are involved in immune cell functioning and arterial wall inflammation. The second is inflammation that's caused by COVID-19 can worsen atherosclerosis and increase the risk of plaque rupturing. The third potential point of correlation is the treatment modality, which we will revisit in conclusions after we've had a chance to consider the study's results. Moving on to the study itself, these are some common cofactors that our patients had. Over 2/3 of them are male, which is fairly common in large-scale cardiovascular disease studies. Nearly 1/3 of them were former or current smokers. Over 1/3 were diabetic, 2/3 had hyperlipidemia, and 3/4 had hypertension. How were these studies selected? We did a search on the PubMed database and screened and evaluated 112 articles. 106 of these were excluded due to insufficient data, and this was mostly because the primary focus of that study was not aligned with the focus of this meta-analysis. We also excluded case studies and other meta-analyses. So a total of 3 studies were included in the meta-analysis, and an additional 3 were not used in the primary data, but were used for background information. And as a quick clarification, here is how we organized all of the data. So all patients included in the study had a myocardial infarction, and they were split up into 2 cohorts, those who had COVID-19 at the time of their infarction and those who didn't. We then looked at the survival versus mortality of each group. My study also had some limitations due to limited available data and small study selection. The I2 value of 78% indicates high heterogeneity among data, and this could be due to one or more of 3 common factors, which are publication bias, differences in study design, and chance variation. Small-scale studies are more susceptible to the latter 2. And another potential reason is timing, because there were many more studies that examined the correlation between COVID-19 and cardiovascular disease that were published shortly after this meta-analysis was completed. And they considered a variety of factors, including treatment modality, door to balloon time, vaccine status, ethnicity, and inflammation. So the results of this study established that there is indeed a risk ratio between having COVID-19 at the time of your heart attack and myocardial infarction mortality. What exactly does this mean? We're going to examine potential causes for correlation, as well as inflammation and treatment modality, and finally look at areas where this can guide future research. Inflammation happens when cytokines that are triggered by COVID-19 infection aggravate existing atherosclerotic plaque. When this plaque ruptures, we have a thrombosis and an MI. Macrophages are a type of immune cell that engulf lipids and cellular debris, and in the process, they become foam cells and contribute to unstable plaque that ruptures. Another potential point of correlation is the treatment methods. The data was insufficient to calculate percentages, which could potentially be due to the delay in treatments and data collection during the pandemic. And as we can see in the first few rows and throughout the table, those who had COVID-19 infection at the time of their MI got less percutaneous coronary interventions and got more fibrinolytics and medical management, which are non-invasive treatments. What does this mean for future research? This study establishes an odds ratio and correlation between COVID-19 positive status and increased MI mortality. However, we need more retrospective studies to study the correlation between increased post-MI mortality and COVID-19 positive status to explain whether the increased mortality is purely due to inflammatory responses or is in conjunction with other significant factors such as MI treatment modalities like PCI versus medical management and delayed treatment. Additionally, having COVID-19 at the time of MI could have impacted door to balloon time, and other areas of consideration for future research are further examination into whether cytokines triggered by COVID-19 can have lasting effects that increase the risk of cardiovascular disease and MI mortality. We can also do cohort studies to track patients who survived an MI while having COVID-19 and compare them to a group who also survived an MI but did not have COVID-19 at the time of their MI. And we can use this to examine the risk of MI reoccurrence or mortality of future MIs based on previous COVID-19 infection. These are my references. Thank you so much. Are there any questions?
Wonderful. Thank you so much for sharing. One question that I had is how did you go about finding like the data and the studies that you ended up using? Was that a challenging process? Was it hard to kind of pick and choose what was most relevant? I'd love to learn a little more.
That's actually a really good question. I'm glad you asked because I have a little anecdote.
Oh,
So we did a search on the PubMed database and like I screamed through a bunch of articles and there was always like something like prevented us from using it. Like they had all of the data we needed, but there was one category that didn't fit. And initially, my study was actually supposed to examine the correlation between COVID-19 and having a myocardial infarction, but we didn't have enough data to study that and to establish an odds ratio. So instead, we pivoted to studying the correlation between COVID-19 and mortality of myocardial infarctions.
very cool. Yeah, well, way to like pivot and be flexible on what will make for good research, right? That's awesome. Thank you so much, Oh my gosh, thank you so much, Shruti. The other question I wanted to ask you, that someone actually will DM to me is, what is the most unexpected thing you learned?
I think the most unexpected thing I learned was actually after we did the data in the conclusion section, and it was here. So with the treatment methods, so I was originally thinking just about the biochemical reaction, like inflammation, cytokines, like how is this creating the affecting the physical process of an MI. But then when I looked at all of the data and I kind of reread through a lot of the studies that we included, I realized that during the peak of the pandemic, people were really scared about getting COVID, about like infecting themselves, their loved ones, their other patients. And so I wanted to examine whether people who had COVID-19 were less likely to receive an invasive treatment like a percutaneous coronary intervention versus non-invasive.
Wow. Awesome. Thank you so much, Shruti. There is also another question for you in the Q&A box. If you want to like type an answer in, I do want to keep moving just to make sure everyone has enough time. But if you can answer that asynchronously, I'm sure the question asker would greatly appreciate it.
Of course, I will answer that right away. And thank you so much, everyone, for listening.